Annual, thank you, is that better? Morris BLUM Memorial Lecture, also in the form of pediatric grand rounds. I want to tell you a little bit about Mo BLUM, and then I will introduce to you our 2017 Memorial Lecturer. Morris BLUM was born in December of 1912. He was orphaned at the age of 5 as a consequence of the great flu pandemic of 1918. He was taken in by his aunt and uncle, completed high school, went to Long Island University, and subsequently to Buffalo University. He trained in dentistry. After he served in the Army during World War II, Mo returned to New York to open an office in Queens, where he continued to practice dentistry until he retired at the age of 77. He had 2 kids, Nancy and Bob. And it was Bob BLUM who came to Minnesota as a pediatric resident back in 1973, and he remained on faculty here in pediatrics. He established the Adolescent Health Program and chaired the Division of General Pediatrics and Adolescent Health from 1978 until 2004, and then went on to where he is now as a Bill Gates professor in the School of Public Health at Johns Hopkins University. I met Bob in 1978 when he began the Adolescent Health Program, and that was also the beginning of my career in the field of adolescent health. Morris BLUM, Nancy and Bob's dad, had a number of distinguishing characteristics, but I would say foremost among them was a deep love of learning, a real commitment to science and research. And it was because of that commitment that upon his death, his children and his extended family established the Morris BLUM Memorial Lecture, really to assure that we here at Minnesota will always have the opportunity to be enriched by the greatest minds in adolescent health. And that is the perfect segue for introducing to you what I consider to be a great mind in the field of adolescent health, Vincent Guilamo-Ramos, who is a professor of New York University, widely recognized for a wide-ranging, interdisciplinary talent about taking on what I consider to be the real lightning rod issues of adolescent and young adult health in our communities and in our nations. He is focused through his intervention work on creating strong connections, open communication between parents and their adolescents, particularly around sexual and reproductive health questions and concerns. And I will tell you that Vincent is somebody who moves easily between community and university. He is a sought-after mentor, teacher, ally, and partner. And we are just so happy to welcome you here to Minnesota. Let's give him a big Minnesota welcome.
So good morning. Thank you very much for that introduction. It's really nice to be here. I feel very honored to be the speaker for this year's Memorial Lecture. It's 7:30, and so I'm really happy to see a full room, and I thank you in advance for your time and attention. So I'm going to actually talk about 3 things. The first part of my presentation is just to kind of set the stage. Most of what I'll present, I think folks in this room are familiar with. But then I'm going to talk about this notion of triadic interventions and the involvement of parents with providers on behalf of adolescents, and ways that we can link those 3 things together to try to improve adolescent health. And then I'll provide one example from my group at NYU called Families Talking Together, FTT, and one of our replication studies, which was done in a pediatric clinic in the South Bronx in New York City, and involved providers, parents, and adolescents. I hope that I'll be able to sort of hit the right mix of sort of lessons learned or things that we benefited from this experience of developing FTT, and that will be useful to all of you here in the room. So I'm going to very briefly talk about adolescent sexual and reproductive health, and just kind of sets the stage a little bit and kind of review some of what kind of weighs heavily on my mind as I think about my work and sort of approach the issues that I'm going to talk about. in my presentation. So I think most of us are familiar with this. This is really demonstrating the proportion of youth as a function of age that report experiencing sexual debut. And no surprise, in early adolescence, most teens or most young people are not sexually active. But as young people move from middle school to high school, there's sort of a rapid transition. And certainly by the end of high school, the entry into young adulthood, the vast majority of young people will indicate that they have in fact experienced debut. I share this because one of the things that you'll notice in the kinds of interventions that we develop at CLAP, the Center for Latino Adolescent and Family Health, is that we try to time our interventions based on what's happening in terms of the developmental trajectory of sexual behavior. So it's no surprise that early in adolescence, 10 to 14, we're primarily focused on delaying sexual debut. But then the focus of our parent-based work shifts around 15 to 19 and starts really thinking about how to keep young people safe as they're engaging at a greater frequency and a greater proportion in sexual behavior. You can see here, again, sort of sexual behaviors among high school students in the United States. And you can see the same basic pattern. Not only are more young people reporting that they've ever been sexually active, but if you look at the number of young people that are currently sexually active who indicate in the past 90 days having sex, you can see that same basic pattern is going on from 9th to 12th grade. And then also as far as the number of partners, as young people are getting older, as they're moving through high school, they're indicating a greater number of partners. And so the sort of dynamic that operates is that young people tend to, despite how they're depicted, they tend to have actually monogamous relationships, but the time periods tend to be very short. And so they may have serial monogamy, and their relationships may last only a couple of months. There are periods where they may feel like things are pretty intense, they're in love, this person matters, they're going to be together forever, and then that ends and they may move on to another relationship. And so that's what that basic pattern is. But it's my way of saying as teens get older, they're more likely to have sex, they're more likely to be currently active, and they are experiencing, as they get older, more sexual partners. We've done a great job as a country at lowering our teen birth rate. Our teen birth rate is still too high, but we've had more than a 50% reduction since the peak period. I think on this slide, what I'm trying to highlight is that we have a tendency to focus on that first teen birth, but there's a significant number of teen births in a given year that actually are repeat pregnancies. And I think we know something about those repeat pregnancies. For example, we know they tend to be geographically clustered in certain places. And so just as an exemplar, Texas is number one in terms of repeat pregnancies. And it's no surprise if any of you, I'm sure many of you saw the Guttmacher report that came out about Texas, but it really lays the foundation, the context of why things are difficult for young people in Texas, and talks about the context of sexual and reproductive health services and how it's difficult for young people to actually access the kinds of health services that would protect them from having a repeat pregnancy. There's nothing about these young people that's different from young people in other places, and I would argue, I don't have time today to do this, but I would argue that a lot of it is shaped by context and that young people are probably more similar in terms of their sexual behavior than different. There are some ethnic and racial disparities. You can see here that the group with the highest teen birth rates are Latinos. Also, African Americans and Native Americans also experience elevated teen pregnancy and birth rates. Again, I would argue that a lot of this is driven by the context in which these young people are embedded, and that there's not something that is innately tied to their ethnicity or race that is driving why we have these disparities. Unfortunately, the CDC this past year put out a report that said that despite all of our efforts and all of our good work, that STIs are at an all-time high. And this slide is really depicting that the burden is really between that sort of 15 to 24 age group. Actually, it's my next slide. This slide is really showing that despite young people representing sort of a pretty small proportion of people that are sexually active, they account for 50% of all of the STIs in a given year. This is the slide that's showing that the burden is between 15 and 24, and you can see that for gonorrhea and chlamydia, which are reportable STIs, that you're most likely to actually be diagnosed in that particular age group. So all this to say that young people are experiencing sexual and reproductive health disparities. Again, no surprise to this group. but this is sort of a concern, and I think we've struggled as a country in how best to respond. One of the things that I've been increasingly sort of focused on in my own career, besides being at NYU as a professor, I just completed a nurse practitioner program. I'm starting actually my first sort of real clinical position as an NP in September at Montefiore Medical Center. Some of you may know the Adolescent AIDS program at Montefiore. And so I'll be working with Donna Futterman. And one of the things that I'm particularly interested in is what I'm depicting here. And so this is an estimate of young people in our country that are living with HIV. And so about 80,000. We know that 60% of those youth that are in fact HIV infected don't know that they're infected. And what's also interesting is that we know that part of our prevention strategy, as well as keeping these young people alive and healthy, is helping them to achieve viral suppression. Unfortunately, only about 6% of HIV-positive youth in our country reach viral suppression. And so that's completely unacceptable just as a standalone outcome. But also what I learned not long ago that's really interesting is that the vast majority of new infections, transmissions occur among people who are undiagnosed, who are in fact infected, and also young people who are not retained in care. And so they may have been referred, but they haven't been retained in care. And so I think this is an area that, again, lends itself really nicely to the kinds of interventions I'm going to talk about. And certainly my work going forward is going to actually tackle this care cascade for HIV-positive youth in ways to involve their families in helping them to retain in care, be retained in care, be sort of re-engaged in care if they've dropped out, and to be adherent to their treatment. Despite guidelines that suggest that young people should receive routine HIV testing at least once a year, if not more, based on their risk factors, most young people in our country have not received an HIV test. This is actually very interesting data that comes from CDC. 90% of adolescents have never been HIV tested, only 10% have. And so again, I think that these are areas that I think are really prime for the kinds of interventions that I'm going to talk about in just a second. So I'm going to shift. That first part of my presentation was just really, really quickly trying to lay the foundation of why this is an important area. I think for this audience, that's pretty clear. But I want to talk about the major approaches that we as a country have sort of used in order to respond to what I laid out sort of previously. And so we've got a number of interventions. I think these things are terrific and that we need more of them. But basically, in a nutshell, we have a lot of school-based efforts that typically in a classroom setting, a young person receives hopefully an evidence-based curriculum that is designed to help reduce their risk behavior. We've increasingly relied on environmental or structural interventions. This may be some way that we're manipulating the environment or the context, perhaps making condoms available, for example, in a restroom or someplace where young people can access what they need in order to protect themselves. We've moved to digital and sort of technology, online, media, those kinds of interventions. I think there are a lot of questions about digital and technological interventions, about the efficacy, but we certainly have increasingly been using that approach to reach young people. Community-based programs, and then increasingly behavioral economics or incentives that are designed to drive adolescent decision-making. And then we've got provider or clinic-based interventions. I'm going to focus on that because I think that's the context that's most relevant for this group. But I think all of these things are really, really great strategies for trying to address the kinds of issues that I've laid out in the first part of the presentation. But I do want to highlight that what they all have in common is they all put at the center of their effort the adolescent. And so they really are designed to target the young person, and they view the young person as sort of the focal unit for intervention. We know that healthcare providers are really important. They're trusted by parents, by their adolescent patients. We do lots of great things like screening, testing, treatment, prevention, health education, anticipatory guidance, all sorts of things. There are lots of guidelines nationally that suggest that we should be doing these things, that we are in fact effective at doing these things, that we play an important role in adolescent sexual and reproductive health. There are some advantages to these provider-based or clinic-based interventions. Adolescents generally perceive that their healthcare providers are experts, and for the most part that is true. I think there is recognition as a whole that we probably could do better in terms of our ability to address issues of sexual and reproductive health. But most adolescent patients see their providers as experts. Also, we can often provide treatment immediately in a number of situations. We can tailor treatment. We can respond to patients' needs. And we also can use every contact with an adolescent patient as an opportunity to try to intervene. I think these are sort of some of the things that are really advantageous about clinic-based or provider-based interventions. We do know that there's actually this month, I think I just read in the Journal of Adolescent Health in the August issue that's coming out, there was sort of a big push for the adoption of a new curriculum for adolescent health that I believe, Michael, was developed with SAM. I think it was a SAM-based product. And so there's an article in the journal, and one of the kind of points that is made in the article is that healthcare providers may feel varying levels of comfort in terms of addressing issues regarding sexual and reproductive health. There may be issues around sort of legal parameters or ethical concerns. They may be inadequate time. I know I've been quite surprised in my own training, the limited amount of time that I have with adolescents. I'm working in New York City, in the South Bronx, urban area. The young people have lots of issues going on. They're generally healthy. A lot of the issues that they're facing are about context, but we have very limited time with them. And so that's been something that's been a challenge given the kinds of issues that are presenting. And we know that there's underutilization of services, particularly among adolescent males. But in general, young people are not coming in for preventative and sort of health and wellness visits, more for acute issues, and they don't come to us as much as they probably should be. I think that this has been well sort of documented. There's this sort of report that I have found very useful from the Institute of Medicine that talks about some of the reasons why adolescents underutilize health services. We know that the underutilization varies by race, ethnicity, obviously by insurance status, but also by income and by gender. Lots of reasons for this. And so I won't review all of these, but I will say that we know that cost and access and the kinds of services that are provided, as well as young people's perceptions of their need, that those all play a role. But one of the areas that I think doesn't get enough attention is how to effectively partner with parents in order to increase utilization. You know, parents are really interesting because they can directly or indirectly shape the relationship between the healthcare professional or provider and the adolescent patient. You know, parents can be gatekeepers. They can say yes or no often. They can support access or they can sort of inhibit access. They can endorse the provider, or they can disagree with what the provider is saying. They can send conflicting messages, or they can actually agree. And so despite many of our settings where young people do have the right to sort of come in and access services, it doesn't mean that parents won't weigh in or they won't be interested in knowing kind of what's happening. There are some challenges that providers actually face in engaging parents. Obviously, confidentiality is a big one. The autonomy of the adolescent to make decisions regarding their own health, but also respecting confidentiality. And then, discomfort, talking about topics like sexual and reproductive health with parents. These are things that have come up in the literature and I think are probably familiar to the folks in this room. I think some of the advantages when we involve parents, it's really terrific. That the parent has a relationship with the provider, with the health institution. There's an opportunity to actually influence what's happening between the parent and the adolescent because of their relationship with the provider or the health institution. Healthcare providers can directly give parents information about the health issues that the teen is facing, and parents can help healthcare providers to better understand the adolescent and the specific nuance or what makes their adolescent child sort of different or what their preferences are. I think the box that is blue is what I really wanted to highlight, that by involving parents, I think increasingly we're seeing that there are better outcomes. And I know, for example, I highlighted that one of the areas that I hope to sort of address as I move forward is this issue of that treatment cascade for HIV-positive adolescents. And so we know, I've seen some data that was recently published in the Lancet about young people living with HIV, and when their parents are involved in their care, they achieve viral suppression at much higher levels relative to youth that are navigating on their own. And so I think we have lots of evidence that when parents are involved in meaningful ways, that it's sort of easier to retain young people in care. They're more likely to adhere to treatment, and we get better outcomes. The challenge is, how do we do that, balancing sort of some of the issues that I've laid out earlier, autonomy, confidentiality. And I don't know how this group feels as a whole, but I would argue that while there's been a lot of discussion about the involvement of parents, I think that, and so let me know during the Q&A if this is a fair comment, but I think that for the most part, the dominant message has really been focused on the adolescent patient's rights, their sort of ability to decide, their confidentiality, and there's been less of a focus on how to balance that coupled with meaningful involvement of the parent in ways that make sense and that sort of keep those things sort of appropriately sort of in each of their respective roles. And so I'll talk about that. So we know that young people are heavily influenced by their context, and we know that one of the major sort of factors in their context are their parents and their families. And so surprisingly, when I first started down this path of working with adolescents, maybe a little more than 20 years ago, I initially was focused directly on the adolescents. And at that time, there was lots of work that was coming out about the important role of families in shaping adolescent decisions regarding a range of issues, including sexual and reproductive health. And more, I think there's growing recognition. I would say there's even just widespread acceptance at this point that parents really do matter and that they can influence important decisions, that they can be sort of leveraged on behalf of their adolescent children to improve kind of outcomes. There's lots of data. This is just one source that I've presented here from the National Campaign to Prevent Teen and Unplanned Pregnancy. When young people are asked who's most influential in your decisions regarding sex, younger adolescents and older adolescents report their parents. Interestingly, if you look at the other sort of indicators or the other groups of sort of people that are influential, there's sort of a big disparity between parents and all the other groups. And I was surprised that on this list, it didn't sort of jump right out that there were healthcare providers. That's interesting to me, right? And so it's friends, media, religious leaders, siblings, teachers and educators, someone else. And so parents really do matter. They're very important, and they can really facilitate the kind of work that we all do on behalf of young people. There's lots of evidence for this. I put up a couple of references, some of my own, but obviously there are lots of people working in this area. And so we know that parent-based approaches can be tied to delaying sexual debut, but not just delaying sexual debut. Greater correct and consistent condom use, reductions in the frequency of sex, greater uptake of HPV vaccine, more likelihood to be HIV tested, and then better treatment outcomes. Again, thinking of the example that I provided regarding the HIV treatment cascade for young people. Parents really matter, and we need to think about engaging them in meaningful ways. There are two basic areas that have been studied in terms of family influences. One area deals what's called the family structure, and another area deals with the family process. The family structure deals with things like the family composition, the circumstances in which the family is embedded, the familial context, issues like poverty and the socioeconomic level. And then less studied has been family process, and these really boil down to three things: parent-adolescent communication about sex, effective monitoring and supervision, and very practical strategies for monitoring and supervision, and then how do parents build meaningful relationships with their teens in ways that will support health and well-being. And so I've gone through these three areas. I think we have seen, not only for our own country, but from reports, for example, from the World Health Organization, that irrespective of the context in which adolescents are growing up, the kinds of families that they're embedded in, that these three things matter. That, parents talking to their teens is important, that how they are monitored and supervised is important, and then also how parents build a strong relationship with their teens is important. I should say that when I use the term parent, that I have a very inclusive, broad definition, that it's not just biological parent, but it's whoever is the primary adult caregiver of that adolescent, that is the parent. And so for our work, oftentimes it's not the biological parent. It can be a step parent, it can be a foster parent, it can be a grandparent. It's whoever the adult is who is caring for that adolescent. So there are lots of advantages to family-based approaches, and there are some challenges. And so I'll talk about some of the advantages. Timing is flexible, okay? So that's really terrific. There's no reason why throughout the course of adolescence from 10 to 19, we can even go as high as 24, that parents can adopt different strategies to actually try to intervene. You know, a lot of the other mechanisms for trying to influence adolescent sexual risk behavior, there's sort of a dose at a particular point. So if you're in a school in 6th grade, they do the curriculum, that's when you get it in 6th grade. But the kinds of things that we can work with parents on can be done throughout adolescence, and what parents do can actually change. And that's kind of a big area of my work, thinking about how to give parents supportive guidance throughout the course of 10 to 24, and basically help them to do what's most relevant at that time. It can be implemented in line with cultural beliefs, with religious beliefs. I've been surprised over the past 20 years that I've been invited to partner with lots of groups that I probably wouldn't have been invited to partner with had I been trying to directly target the adolescents. At the heart of a family-based intervention is a notion that we as providers or whoever it is that's delivering the intervention is really being medically accurate, honest, completely transparent with the parent, but ultimately it's the parent's decision if they want to, how they want to, and what they want to share with the adolescent. Parents are generally motivated to keep their adolescents safe, to have them be protected, healthy. Many adolescents actually want guidance from their parents, okay? And so this is something that I would really highlight. Adolescents know that their parents, for the most part, are trustworthy. They do believe that their parents have their best interests at heart, and they want specific guidance. And while it may be the case that, you know, again, I'm sort of curious what you guys think about this during our Q&A, that many times young people are seeking information from a range of sources, you know, from the internet to the school-based health clinic to their primary care provider, you know, from different folks in their context. They want guidance and they want to know the perspective of their parents. And again, this has been substantiated by many, many studies that have looked at adolescent preferences. Information can be tailored. Family-based approaches can really fit the individual adolescent. They don't have to be sort of for a broad group. You know, using the example again of the school-based, usually there's a class, there's a group of adolescents. It's more of a one-size-fits-all. And so parents can do things throughout adolescence. It can be tailored. They can feel comfortable based on their religious values, their cultural beliefs, and they're generally motivated. And probably most importantly, adolescents really want to hear from their parents. Some of the challenges, parents may lack perspectives on how to be most effective. I think what's interesting is that we shouldn't try, and this has been sort of another big part of my work, we shouldn't try to make parents like all of us. The kinds of things that parents should reinforce, that they should actually deliver to their adolescent child, they're actually different. They're not the technical and very specific kind of health information that perhaps we might provide a young person. Parents have unique content. I'm going to talk a little bit about that in the next part of my presentation. But they have a unique influence, and that's what really should be maximized. And so we shouldn't try to make them healthcare providers or give them lots of technical information that will confuse them or overwhelm them. If that is our approach, they will feel like they want to defer to us. And in fact, what we want is that we want to be able to do all the things that I presented in the earlier slide that target the adolescent directly and also benefit from the unique influence of the parent. But the parent needs to do what the parent is most comfortable with and what we know will shape the young person's decisions regarding their sexual and reproductive health. We know that many families are complex. When I first started down this path in developing these interventions back in 2000, a lot of the feedback that I initially received was that the families in the South Bronx and Harlem were experiencing too many disadvantages. They were economically really at the lower SCS level. They had sort of very complex family systems, lots of things going on, and that they wouldn't really be that amenable to these kinds of interventions. And sometimes people call them hard to reach. Sometimes they call them, believe it or not, dysfunctional families. They were characterized in not so positive ways. And so I think that my experience has been, that's the very place where I've chosen to kind of place my work, and that's where I actually do all of my work. And so I would argue that these families represent more the reality of what family life looks like today. and that I think many families are complex, and that many families are challenged by multiple demands, and that I think despite those challenges, I have found that if we make things very pragmatic, very straightforward, we're not trying to sort of be the encyclopedia of parenting, but we have very practical strategies that we try to introduce when we have these brief opportunities to intervene with a parent on behalf of the adolescent, that we can actually have a pretty big effect. And I'm going to show you guys an example in a second. So what does all this mean? What this means is that we know healthcare professionals, providers, all of you guys here in the room, you really matter. The kind of work that you do on behalf of adolescents is critical. It's essential. We know that parents also really matter in terms of adolescent health. And the question becomes how to bring these three things together: the parent, the healthcare provider, and the adolescent. So what are triadic interventions? Triadic interventions do just that. They actually are a way to bring together the provider, the parent, and the adolescent patient. And so an intervention becomes triadic when a provider does something proactively to involve the parent on behalf of the adolescent's health. There are some basic premises that I think are important. Often the provider and the parent, and for that matter, the teen, have some common goals. They may not have complete common goals, but they have some common goals. There are sort of respective roles that are often sort of, they can overlap, but they can also be distinct, but there's a great potential for a synergistic positive effect. And I think this is the part that excites me most, that when these three things come together, that there's a potential for really improving the health and well-being of adolescents. Carol Ford from UPenn, many of you probably know Dr. Ford. She really pioneered some years back in the Journal of Adolescent Health this notion of triadic interventions. And so she presented this figure, which I'm presenting here, and basically it shows the healthcare professional shapes adolescent health outcomes through encouraging and reinforcing healthy behavior, diagnosing and treating health problems, providing referrals. There's also recognition that the parent is shaping the adolescent health outcome through monitoring and supervision, through communication, and through the parent's interests and desire to be involved. There's also the connection between the healthcare provider and the parent. And so this relationship allows for the parent to become familiar with the healthcare system and the provider, as well as it allows the provider to give the parent information that may be useful in terms of the adolescent health, circumstance. And so in Carol's model, she also has an indirect, the arrow that goes from the provider to the line that cuts across from parent to adolescent patient. And that indirect effect is really where the provider is reinforcing things that the parent is trying to do. And so the parent may be trying to effectively monitor or communicate, and the provider is actually providing support to the parent in order to do that more effectively. I would argue that the parent also, and I've added this blue line, the parent also can sort of moderate the relationship between the provider and the adolescent patient, and that there are many things that the provider may be doing with the adolescent that the parent can actually reinforce and can really try to support on behalf of the adolescent's health. To me, this is the heart of what a triadic intervention looks like, and I think there are some things that we have learned in sort of taking Carol's model and trying to apply it in sort of the real clinic context in developing families talking together. So a couple of things that we learned, and these are just some lessons from our own work. They may not necessarily be relevant for this group, but I just wanted to present them because I think they've been really helpful. And so basically important to integrate the intervention into routine care. Again, one of the things that we saw early on in our work is that if we tried to disrupt the clinic, we were going to fail. There was a large flow of patients and there was very limited time. And so we needed to look for ways of building our intervention into what was happening on a routine basis. It was important to maximize the health provider sort of influence. And initially, we thought that it would be the actual healthcare provider that would deliver the intervention to the parent. That became very apparent early on that wasn't going to happen. Provider was too busy, had too much to do, and too much demand in terms of patient workload. And so it became important that the provider actually endorsed the intervention, that the parent perceived the intervention as part of that visit, part of the clinic, part of why they were there. But it wasn't going to be housed directly with the healthcare provider, whoever the primary care person was for that adolescent. It was delivered by someone else in the clinic that was sort of an extension of the healthcare provider, and that was deemed as being part of the clinic team. Outreach to parents and adolescents directly in the waiting room. We actually went right up to the families while they were waiting. One of the things that was really interesting is there was lots of downtime where maybe initially the parent and teen went into the examination room. The parent typically stepped out after a couple of minutes and then would sit in the waiting room. And depending upon how busy things were in the clinic, it could be quite a while that they were waiting. And so during that time was when we decided to take advantage of the parent just sitting there. It was a real opportunity to intervene. And we brought the parent to a private setting, and we started delivering the intervention while the adolescent was being examined by the provider. We state clear goals of the intervention for the parent and also the adolescent. I've mentioned already that we package the intervention as part of what's being offered by that clinic to the family. And so it's not something else that's distinct. It's part of that visit. It's really a way to help support the teen's health and support the family, through this service that the clinic is providing. We, focused on things that were developmentally appropriate, which is why I presented that sort of those initial figures at the beginning of the talk. The example that I'm going to give you today was an intervention developed for 10 to 14-year-old adolescents. And so it really was focused on delaying sexual debut, but it also addressed issues around frequency of sex, as well as there was some content about discussing contraception when the teen is a little older. And then providing, parents with concrete information. Parents often, in my experience, and I've been studying parent-adolescent communication for about 20 years now, parents often have somewhat vague messages when they talk to their teens. And so teens will often say to us that they don't fully understand what their parents were trying to communicate. And so they want specific guidance. And so the more concrete, the more practical, the more sort of straightforward you can be with the parent, the better it's going to be in terms of their ability to influence the teen. So I'm going to transition to families talking together, FTT. FTT is an intervention that has not only been implemented in clinic settings, it's been implemented in some of the other settings that were in the figure that I presented earlier, including schools and community. But a big part of our work has been identifying pediatric clinics and implementing FTT in that particular setting. And so the program is, for parents. Most of the time it's a mom who's at that visit. Unfortunately, it hasn't been a dad, but it's been a mom who's been in the waiting room. And as part of that visit, the mom is taken into a private area of the clinic and is given the intervention. And so she receives a family workbook. She receives some resources for the teen, and she receives some homework assignments that we'd like her to actually complete with the teen. The homework assignments involve a story that actually addresses the main content that is tied to the empirical basis of why FTT works. And so I can't present all the formative work that led to why specific components, but maybe during the Q&A there'll be some questions about why we chose to focus on certain content. It's really practical. It's designed to be brief. It is not designed to change their parenting style. We are really reinforcing specific content in the communication as well as specific monitoring and supervision strategies. So we were funded to develop the program and also evaluate it. And so we had a couple of years to do formative work to figure out how the intervention should fit into the clinic. And then we were given a couple of years to actually do the RCT to evaluate the effects of the intervention and did it matter. We had some project parameters. It had to be very practical. And so they didn't want something that minus the research funds couldn't be sustained by a clinic. It needed to be, sort of so straightforward for the parents. It couldn't be very complex. We know there are big issues with recruitment and retention of parents. And so many times I'm confronted with institutions, not just healthcare providers, but more commonly it's schools or community-based organizations that are trying to engage parents, and they kind of do it in a way that is probably not going to result in having the broadest reach. And so they may set up things like special events for parents. They may have food, or they may have childcare, or try to entice parents to come. And I don't think that's the way that we should be doing this. I think we should think about where parents already are. And so my example from the clinic is that we observed the clinic and we watched the flow early on in our work. And we saw that the moms were sitting in the waiting room for quite a bit of time. And so that became the point where we decided we would not interrupt the normal flow of the clinic, but we would take advantage of this opportunity to reach the parent. It had to be set up to reach a broad number of individuals. And it had to have a high likelihood through strong sort of social and behavioral science that it would influence the target behaviors. And so we rely on some pretty nice theories of adolescent sexual risk behavior, but also some family theories about communication, monitoring and supervision, and building quality relationships with your teen. I won't have time to go through all of this, but this is basically a model that kind of lays out the kinds of factors that we're looking at. And you can see that we've got some proximal determinants that are depicted sort of to the left of behavior. These are things that, that we believe shape the intention behavior link. And then also more distally, there are things that shape intentions. And so all of these things are measured and they're applied to 3 levels. And so on the far right, the model is applied to the parent because the kind of behavior that we're trying to influence with the parent is communication, is monitoring and supervision. At the level of the adolescent, we're applying the model to their sexual behavior. Depending upon the age, it may be a different behavior. For our purposes, 10 to 14, it was delaying sexual debut. And then they're also applied to the provider, trying to understand how the provider could endorse the program and what kinds of knowledge or skills, how salient it was to the provider, what their previous habitual or automatic process had been or experience with endorsing such programs, their beliefs about such programs, the normative influences in the clinic about endorsing such programs. And so we applied all of this. And if I had a lot more time, I would show you guys what predicted provider behavior, what predicted adolescent behavior, and what predicted sort of parent behavior. And so what I will say is that the predictors are slightly different. And so I'll give you some insights as I proceed. So what we wound up doing is I mentioned already that the provider wound up not doing the actual program. It was, really clear that there was no time for that. They needed to endorse the program. We had a face-to-face session in the clinic. I've talked already about the parent being asked to come to a private room and actually was working with family interventionists. There was a workbook, and then there were the homework activities. It was really straightforward in something called the basics, lo básico, Spanish version, and it was really focused on really very sort of clear and simple and straightforward parenting strategies, things that we wanted the parent to do with the teen. I've mentioned the clinic was in the South Bronx. It's a very large urban clinic, about 70% Latino population, 30% African American. The families were recruited directly from the waiting room. There were primarily mothers who were there. And for this study, we approached 326 dyads, and we were able to recruit 271 that were found, actually that's not true, 271 were found eligible to participate, and then there were 7 refusals. We had a baseline, a 3-month and a 9-month follow-up. There were 2 arms to the study. There was an experimental arm that received FTT. There was a control arm that just received the standard of care. And I'm only going to show you the adolescent outcomes, but we had outcomes for the providers, for the adolescents, and also, for the parents. And so you might imagine what we were interested from the providers was endorsement, for the adolescents, whether or not they became sexually active, the frequency of sex, and for the parents, did they communicate, did they monitor and supervise more, and so I'll share with you some of the results. So you can see here our basic consort diagram with what happened, and so you can see our 2 arms. I've just explained this and kind of what we had in our RCT design. And at the 9-month follow-up, sort of what we had. And so first, our demographics, you can see here the parents and the adolescents, the mean ages of the adolescents around 13, about half male, half female. You can see here the parents, their mean age, and then also large numbers of Latino families. That's because the neighborhood is mostly Latino neighborhood, and then also some African American families. There was a high level of families that speak Spanish in the home, which really speaks to issues of acculturation. And this is a community that has a high concentration of immigrants, with the adolescents largely being born in the U.S., but their parents being foreign-born. So here are our results. And so you can see at the baseline, the two arms were roughly equal. There was no difference in ever having sex. And so about 6% of the sample indicated at the start of our study that they had become already sexually active. You can see 9 months later that in the control arm, about 22% indicated that they were sexually active or had been sexually active, and the experimental arm stayed the same. There were no transitions to sexual experience there. You can see for oral sex the same basic pattern, and you can see for the frequency of sex for those young people that were in fact sexually active, that there was a tendency for young people in the experimental arm to actually report a slightly reduced mean frequency of sexual behavior in the past 30 days. And so we saw that as being really, really promising, a really great result, especially when you think about it was one session in the clinic, and it was a pretty low-level effort in terms of trying to shape, young people's behavior. We've replicated this effect with a longer follow-up time and a much larger sample, and we've replicated the effect in different settings with parents, and have had really sort of similar results. Our program has been picked up by HHS and by what's called the TPP registry from the Office of Adolescent Health. And so it is available through the Office of Adolescent Health as one of the evidence-based programs, or I should clarify, it's indicated on the Office of Adolescent Health website as being one of their evidence-based programs. It's available through the Center for Latino Adolescent and Family Health, and it's been disseminated in a number of settings. So I'm going to stop there. Hopefully that was interesting. It's a quiet group, but I'll take some questions and see if any of that resonates with the crowd. Thank you very much for your attention. So any questions? Yes.
So on the last slide you showed there, it indicates that it's designed for Latino and African American communities. I'm wondering why HHS chose to market it or advertise it that way rather than more generalizably.
So I think so a couple things. So the reason why we developed for Latino and African Americans, largely because that's where the greatest disparities are, and because our local community where we were planning to do the study, that's who is there. And so it made sense at the time that we would focus on Latinos and African Americans. Since then, the program has been replicated with non-Latino, non-African American. And I guess I would argue that HHS put the program up on the website as being for those two groups. I think that's what it says on the website, because that's what the evidence is. The data are based on those populations. I would argue, though, that the kinds of influences or the kinds of mechanisms that we're talking about, communication, monitoring and supervision, and building a quality relationship, that's not unique to just Latino and African American. We've replicated FTT different parts of the country with different kinds of Latino and African American families, but we've also gone to India and also to the Dominican Republic with Dominican and Haitian families and replicated FTT. And again, we focused on similar kinds of content, helping parents to communicate, and it's been effective. So great question. Yes.
Great talk. What was the nature of the visits that those kids were in the waiting room for? You had a randomized sample. Were these kids injured, routine, well-child sorts of checks? What brought them to the clinics?
So in New York, there's, I don't know if this is true here, but in New York, the young people have to get an annual physical to go to school. They've got to do that every year. And so we timed it so that we knew they would be coming in. And this particular clinic has all the school-based health clinics, so they signal at the school that they should go in. And so we were able to be there. We did not approach families that were there for sort of an acute visit if the child was sick. It was just for those wellness visits. And so that's who we screened. But there were a lot of young people sort of at that time of the year coming in for a visit. There's also, it's a very dense area in the South Bronx, and the clinic has a lot of patients, not just adolescent, but it's just big operation. Yes?
So it seems like it's a piece of written information that was handed out to the families. Were there aspects of health literacy you had to take into account? And with the information that was handed out, what were your insights about what were the 2 or 3 most effective pieces of information that the families took away and were able to then implement with their child?
Sure. So I would say that it is definitely a family workbook that is written information. I guess I would slightly characterize it a little differently. I think that the insert, that is the basics, is really designed for the interventionist to walk the parents through a story. And so that story is the story of Marie and Victor, two teens that decide to have sex. And what's in that story is based on the formative work that we actually did that looked at determinants of sexual behavior. And so it really emphasizes what the teens were thinking when they decided to have sex. No surprise that a lot of what motivates adults to actually, and parents to actually do something on behalf of their adolescent tends to be negative health and social outcomes. And so parents are heavily influenced by thinking that their child might get pregnant or might have an STI, might get HIV. That's not what was driving the decision of the young people. Young people were perceiving that they were short-term positives or good things that would happen if they chose to have sex. And so that's one of the things that we really emphasize in the session. We help parents to see that while we want them to be motivated because there are very real risks, that they must address the context of the adolescent's world. And so teens are thinking about things like they're going to be closer to their boyfriend or girlfriend. They're going to be popular. It might feel pleasurable. This is a way for them to be more mature. There's an entirely different set of things that are happening in that decision when they choose to have sex that makes sense for the teen. The challenge is how to get the parent to actually address those topics. And that's what happens in the session through the story. We introduce the story. The parent sees, what Victor and Maria were thinking, and then we teach the parent counters to those kinds of beliefs. We also focus on a couple of monitoring and supervision strategies that are really straightforward: discouraging dating in early adolescence, discouraging too serious dating. If you're going to allow dating, definitely don't want it to be too serious. Not supporting young people being with other adolescents, particularly in a romantic relationship that are 2 or more years older, because we know that is tied to transition to sexual experience. And then really reducing the number of times that a young person is unsupervised, where they have access to a space where there's no adult and they can have an opportunity for sex. These are the kinds of things that we focus on for our 10 to 14 group. For an intervention that I haven't presented today, but for our 15 to 19, we really have the parent endorsing contraception and really helping the teen to understand how to consistently and correctly use condoms and how to access sexual and reproductive health services. And it has an entirely different focus, but it really builds on what parents can do without making them the technical experts. I think there are a couple of hands in the back. Yes.
I'm interested in knowing more about how you measure parent communication, if it's you're measuring certain content that they say they're communicating with their teen about, or if it's a general, like, have you communicated with your teen based on what you learned in the intervention?
So it's absolutely not a general question. We measure 5 dimensions of communication. And so one of the things that, if anybody is interested, you can email me and I will send you this really great guide that I developed with the national campaign. Actually, Michael did the sort of companion piece that reviewed the research. But it's a guide for practitioners on parent-adolescent communication about sex. And I cover 5 dimensions. I cover the timing of communication. When is the best timing? And when should parents initiate conversation? I cover the content. What should parents specifically be saying? There is specific content that parents need to deliver in order to shape decisions about transitions to sex or another sexual and reproductive health outcome. I cover the frequency of communication. What is the appropriate sort of frequency? I cover the context and the style. And then I also address parent barriers to communication. What are the major parental barriers? And then how can we counter those? All of that's in a guide that's online that if you email me, I'm happy to send to you. It's really straightforward, and I think it's really important. What I can definitely say is that it shouldn't just be a general sort of have you talk to your teen about sex. There are specific things that actually speak to this gentleman that is in the front here on the left, what he was asking about, what is the content. That's what's in the story, and that's what we want the parents to address. I think there was a hand here, and I'll swing back. Yes. I think there was one over here, Danny, in the front. Yeah. Yeah. Thank you.
Superb presentation.
Well, thank you.
And I want this for our clinic. And so wondered a little bit about the actual nuts and bolts of implementing it. What is the type of professional who does the intervention with the parent, and the time involved, and kind of the financial aspects of sustaining the intervention?
Sure. So those are great questions. I was just talking about this yesterday and today. And so a couple of things. And so anyone that is trained can actually do the intervention. And so why I say that is because in our FTT sort of program, we've implemented it in different settings with different kinds of interventionists. And so on one hand, we've had professionals that have been social workers, nurses, other kinds of professionals that are maybe health educators do the program. But we've also just worked with community health workers. And in our school-based efforts, we've actually trained parents to deliver the program to other parents. And so it's really less about the kind of training that the person who's delivering has. It's more about understanding the fidelity of the intervention and what the specific content is that actually makes FTT work. And so it's really straightforward, but there's some essential pieces that must be there. And inside of the basics, that's what we highlight. In terms of accessing the materials and the kind of structure for getting trained, so the center provides trainings. We usually do them regionally when we have a large enough group that we can train. And then once a group is trained, we have an access point where you can actually access the materials from a website. We don't sell the materials. We really want it to be disseminated. And the reason why we have them at the access point is because we do periodically update the materials. We've worked on 10 to 14. We are now working on 15 to 19, and the center just completed under Jim Jackard's leadership. He's one of the co-directors, sort of a contraceptive counseling protocol, which is really for the 20 to 25 group. And so we're trying to put something together that will be a packet of resources for families across that entire period. And so I would say email me. I can tell you when the next trainings are coming up. And I suspect, based on being here the past couple of days, that there might be some interest in maybe having something right here, because I got a lot of requests, Michael, from the group yesterday about this topic. And so maybe we can figure out a way to do an FTT training. Once folks are trained, then the materials can just be accessed. The only cost will be the production of the materials, because you have files, but they need to be produced for the families. But it can be very low cost. It doesn't need to be anything fancy. It's truly the interventionist that brings the intervention to the parent. It's not so much about the written materials. And certainly in our work in the Dominican Republic with Haitian and Dominican families, just to illustrate the point, they had mostly pictures that were depicting what we want, the story of Victor and Maria, and the community health workers walked them through and explained what the pictures were depicting, and then they used that to tell the story to their teen. And so it's really about the interventionist and the practice with the parent. Thank you.
Thank you.
I think this gentleman's wanted to ask a question. Yes.
How does the program address sexual orientation?
So that's a great question. And so this has come up a lot. And so the program initially was developed as part of teen pregnancy prevention, and sexual minority youth do have high teen pregnancy rates. And so that's been something that we've struggled with because it doesn't explicitly address sexual minority youth. And I think that that's a gap in the program. Actually, there are many gaps in the program. I would argue that, I think we need to be a little cautious because some of the work that has come out from folks like Caitlin Ryan, who does the Family Acceptance Project, or there's a great person by the name of Dave Hubner who's working on an intervention for parenting, and I happen to be working with Dave on that for sexual minority youth, or a great colleague at the University of Chicago, Alita Boris. Some of what they have found in their parenting work for sexual minority youth is that the mechanisms are slightly different. And so I want to be cautious with sort of generalizing what we have here to that population. What I will say is that we definitely need interventions for sexual minority youth. And so my apologies for that, but thank you for asking.
All right, everyone, it's past 8:30. Just want to let you know that.
Thank you very much. I appreciate it. Thank you.